Hi, everybody. I am really excited to be here and meet you all and tell you about the research that we've been doing to support families during infant feeding, and in particular, the research we've been doing around responsive bottle feeding. So I am an associate professor of kinesiology and public health with the Center for Health Research at the California Polytechnic State University in San Luis Obispo. And the research that we do is really focused on inclusiveness, equity, and supporting new families in the ways that they need support, and making sure that they have the resources they need to support their baby's health. So within this goal and the topic I'm going to talk to you about today, I have 3 parts to my talk. First, we're going to talk about this idea of responsive feeding. It might be a concept that you're already aware of and promoting in what you do, but if it's not, then we'll at least all get on the same page and kind of understanding what it is and why we think it's important for early feeding interactions. Then we'll think about ways of feeding babies, especially during the milk feeding period, and thinking about breastfeeding versus bottle feeding, whether there are differences and why that might be important. Then we'll think about responsive feeding within the context of bottle feeding and how we can support our parents to achieve this. All right, so let's think about the importance of responsive feeding. So we know that the first 1,000 days are what we would call a sensitive period of development. And so this is roughly the period between conception and a child's second birthday. And we know that the experiences and exposures that children have during this window have disproportionate and lasting effects on later health outcomes. So whatever we can do in terms of prevention and intervention during this period, we know we're probably going to get the most bang for our buck because young children are just ready to learn. They learn from early relationships and environments, and so we want to make those as supportive and enriching as possible. In terms of physical health, we know that weight gain during this period is a really important thing to track and monitor. And in particular, we are concerned with rapid weight gain, which is defined as a weight for age Z-score change greater than 1 standard deviation. So if you use growth charts to put this in context for you, this is basically the idea of a baby who's crossing percentile lines, that they're gaining more weight than we would expect them to, based on our growth standards that we have. And research has shown that if a baby exhibits rapid weight change during the first 2 years, that this is associated with increased risk for obesity. And so in particular, this one meta-analysis illustrated that there was over a 3-fold risk for later obesity if a baby gained weight too quickly during early infancy. So this is an important target for our prevention efforts. And I'm sorry, there's marks on the screen here, and I'm not sure how to get rid of them. There we go. So because feeding is one of the most primary influences on weight gain, this is an important target for our intervention efforts. And so we know, though, that it's not as simple as just how much you give the baby. Feeding is complex and it's important, and it's more than just the provision of milk, but feeding is a really important time for bonding, eye contact, social interaction, cognitive growth fostering. These feeding interactions are just a really important time for babies and parents. And so we want to understand them, right? We want to understand what's going on during feeding, where things may be diverging from our hopes and expectations, so that we can find the proper places for support. And so this model summarizes kind of our understanding of early feeding interactions and ways that these interactions may lead to increased feeding amount and accelerated weight gain during early infancy. And so what this model is showing us is that we have this social environmental context of feeding, right, which is really representing the family, the home environment, the relationship between the caregiver and the infant. And both the caregiver and the infant are bringing something to this interaction. The caregiver has an awareness of the baby's feeding cues, and we would hope that they would be able to read and accurately interpret those cues and respond to them in ways that we would consider developmentally appropriate. The caregiver is also going to have perceptions about what a baby should eat, how much a baby should eat, how the baby should behave, and all these things are going to influence their feeding practices and their interactions with their baby. But we also know that babies bring things to the table too, that they have distinct temperaments. They may be more or less clear in their expression of their hunger and satiation cues. And when there may be a mismatch between what the caregiver and the infant are bringing to the table, we might have a discordant feeding responsiveness, meaning that the baby is maybe expressing cues that the parent isn't picking up. The baby needs more or less milk, and the parent isn't understanding that and providing it. And so when we have discord here, then that may lead to increased feeding frequency and amount, which over time may impair the baby's ability to self-regulate their intake in response to their hunger and fullness cues and their physiological needs, leading to overfeeding over time, which may be the underpinnings of rapid weight gain and increased risk for overweight. So I brought to you this term self-regulation. I just want to make sure that you understand that's within the context of feeding, because this is one of our primary goals when we think about outcomes of feeding interactions. And so you may have thought about self-regulation of emotion or behavior. We want children to be able to recognize their emotions and respond in a way that's healthy and appropriate to the context. But we want to think about this with feeding too, that ideally our goal is to raise children who become adults who are really good at recognizing when they're hungry and eating in response to that, but also then recognizing when they're full, feeling those physiological feelings of fullness and stopping eating when that occurs. And research shows that when we're not very good at this, when we're eating in the absence of hunger or we're eating beyond fullness, these are some primary risk factors for overeating and increased risk for overweight. So we really want to make sure to kind of preserve and promote this ability early on in these early feeding interactions. So again, we ideally want a baby to recognize the feelings of hunger, to feel the feeling in their stomach, to feel their crankiness and recognize, oh, this means I'm hungry, and to be able to express that through these hunger cues like rooting or sucking on their fist. We want them to then see that, okay, when I'm feeling this feeling and I express that, I get fed. I get my breast milk or my formula or other foods for the older infant. We then want the infant to recognize the feelings of fullness, feeling the stomach distension and the satisfaction and the sleepiness that might come with that. And we want the baby to then express that fullness and that lead to stopping feeding and eating. So this would be our ideal, but it is contingent, as I showed in the previous model, on the parent or to recognize those hunger cues and recognize that what the baby needs is to be fed and not other things. But we also want the caregiver to distinguish feeding cues from sleepiness or crankiness or reduced stimulation needs as well. We also want the caregiver to trust those cues and recognize, oh, my baby is showing signs of satiation. I think my baby might be full, and be willing to stop the feeding in response to those cues. And again, we may get discord when we have a caregiver who thinks, oh, but my baby only ate an ounce and they should be eating 4 ounces every feed, or there's still milk left in the bottle. So let's just try to get a little bit more, into my baby. And those are behaviors that aren't recognizing and respecting the fullness cues that the baby's exhibiting. So ideally, we want this whole process to be facilitated by a caregiver who can recognize these cues, trust them, trust their baby to be, an equal partner in the feeding interaction, and recognize the importance of responding to these cues as a way of supporting self-regulation of intake for the baby. And part of this kind of trust can be supported by research showing that, that this is an ability that young infants have, that they're actually pretty good at self-regulating their intake, or at least developing this ability during infancy. And this has been shown in a number of different contexts, but we see that infants are pretty good at decreasing, the amount of breast milk or formula that they consume when we do things like increase the caloric density of the formula. So making it more calories per ounce of formula, babies will drink less so that they even out the amount of calories that they're consuming per meal and per day. If we add satiating factors like free glutamate, which is a free amino acid, which is very satiating, babies will drink less. If we present babies with more breast milk, if we increase the supply of mother's breast milk, babies will even out how much they're drinking so that they're drinking a consistent amount over a period of time. And we see that for breastfed infants, when we introduce solid foods, they decrease the amount of breast milk that they're taking per feed to account for the extra calories that are coming in solid foods. So again, over time, we see that babies are pretty good at regulating their intake in response to changes in what they're being fed. But again, this is all contingent on the parent kind of respecting their ability to regulate. And we also see that over time, children get worse at this. And that worsening is related to parent feeding practices that are overly controlling or pressuring or not respective of the child's satiation cues. So again, responsive feeding is what I've been describing here, to put a term to it, this really ability of parents to respond to the baby's needs, to understand what's developmentally appropriate. This way of feeding really supports the development and maintenance of self-regulatory abilities for children. And what this looks like very simply is that the infant is able to signal their hunger and fullness, their needs for breaks throughout the feeding, and the caregiver initiates, pauses, and terminates the feeding in response to these cues. We can think of other examples of responsive versus non-responsive feeding. So responsive feeding looks like the column on the left in green here, that it's feeding on demand versus feeding on a schedule, would be a non-responsive feeding practice. It would be a caregiver who initiates feeding in response to infant hunger cues versus a parent who's maybe watching the time or trying to meet a certain target for how much the baby should consume in their mind. And responsive feeding also recognizes these broader benefits of feeding too, right? It's a caregiver who during feeding is sitting with the infant, is making eye contact, is talking to them, engaging with them, versus not responsive feeding would be a caregiver who is distracted. Maybe they're on their phone or watching TV the whole time and not really recognizing the broader benefits of these feeding interactions. A responsive feeder paces the feeding by watching the baby's signals and cues versus a feeder who is really encouraging the baby to eat more, eat faster, continues feeding even though the child may show signs of refusal. The responsive feeder would gently prompt a child to eat, so there is maybe some encouragement to eat, or in case of when we're feeding solid foods, to encourage the baby to try new foods, but there's no force, right? There's no coercion, that there's also still a respect for the child's preferences and autonomy and their ability to say, no, I'm not hungry, or I'm not feeling like trying something new right now. So to wrap up this section of the talk and to emphasize the importance of responsive feeding, we talked about how early infancy is a sensitive period for many things, but in particular for obesity risk. And so supporting healthy feeding interactions and weight gain for babies is a really important target for our prevention and intervention efforts. We know that feeding interactions are really, a proximal influence on obesity risk, and so they are a good place to focus our efforts. During responsive feeding, the caregiver is sensitive and contingently responsive to infant feeding cues in a way that supports the infant's developing abilities to self-regulate their intake, which we know is an important preventive factor for promoting healthy intake patterns and weight gain patterns for babies. All right, so now that we've established this idea of responsive feeding and really our ideal of what we want to support for caregivers and babies, let's think about breastfeeding versus bottle feeding and how these different modes of feeding might have different implications for responsive feeding and infants' feeding outcomes. So if we think about breastfeeding, we know that it's what we would call a demand and supply system. And the terms demand and supply are presented this way for a reason, because really what happens is that there's infant demand first, right? That the infant communicates to the mother's brain how much they need. And this is communicated by the frequency, duration, and intensity of the infant's suckling. So the infant's body, or the mother's body, is very responsive to how often and how much the baby is consuming. And that's then what's driving the mother's milk supply. And so there are increases or decreases in the milk supply that are in response to infant demand. So this really eloquent system that makes sure that the mother is making enough milk for the baby, given other factors like her physiology or health history aren't interfering with her ability to make sufficient milk. And so in this sense, then, we can think of breastfeeding and responsive feeding as very complementary, right? It's probably going to be pretty hard to be successful at breastfeeding, in both initiating and sustaining breastfeeding, if we're not responsive to the baby's cues. And so that means that responsive feeding is really supporting the initiation and maintenance of breastfeeding. But then, as I'll discuss, there's literature, there's research that's also showing that breastfeeding then further kind of perpetuates responsive feeding, that there's really a complementary process that's going on here. And I want to highlight some really important features of breastfeeding that may kind of support the mom's ability to develop this responsive feeding style. First, we know that during breastfeeding, the mother can't assess how much the infant consumes, right? It's somewhat of a black box for her. She just has to develop this trust that her baby is getting enough milk. And a lot of that trust is based on the baby's behavior. If she sees that her baby settles into the feeding and seems satisfied after the feeding, she's probably going to trust that things are going well. If her baby is sleeping well, and is not agitated throughout the day, she's going to trust that her baby's getting enough to eat. And so these two features are really important for supporting the mom's ability to breastfeed and their trust that it's going well, but also it provides this repeated learning on the part of the mom to watch her baby's cues and learn her baby's cues and try to decipher and understand what those cues mean, so that over time the mom feels like she can read those cues and let that guide her feeding behaviors in terms of when to put the baby on the breast and how long to feed for and when to terminate the feeding. So in terms of research supporting this idea that more responsive feeding styles early on support the initiation and success with breastfeeding, we see that mothers and babies who exhibit better bonding during the first couple days after birth go on to have longer breastfeeding durations. We also see that moms who are more sensitive to their baby's cues during the first 28 to 90 hours after birth, and who continue to have higher sensitivities to their baby's cues during the first 3 months, go on to have longer breastfeeding durations. So these findings suggest that if moms are more sensitive and responsive early on, that may support their ability to be successful with breastfeeding. But then we also see that mothers who breastfeed for longer duration also go on to have more responsive feeding styles later on down the line, even beyond their breastfeeding experience. And again, this is probably partly hormonal. There may be some neural mechanisms, but some of it may also be behavioral learning too on the part of the mom, learning to read and trust her baby's cues. So we see that moms who breastfeed for longer durations have greater levels of responsive feeding when their babies are 1 to 2 years old. And they're less likely to use controlling feeding practices like pressuring their child to eat or restricting their child's intake of certain foods when their children are 1 to 2 years old. So these are some really nice potential benefits of breastfeeding and ways that breastfeeding may naturally complement responsive feeding and promote it. And we know that there are some likely important differences when we formula and bottle feed babies. And research shows that there are different weight outcomes and eating behaviors for children who were formula or bottle fed compared to breastfed. So some of this research shows that compared to breastfed infants who are formula or bottle fed, they consume greater volumes at each feed and over the course of the day. So they're getting more calories routinely. And they are at greater risk of exhibiting rapid weight gain during the first 2 years. We see greater weight gain overall over the first 2 years and greater risk for obesity during childhood and adulthood. In terms of eating behavior, we also see that these children who were fed formula from bottles exhibit poor abilities to self-regulate their intake, which is this satiety responsiveness concept in the last bullet. So they seem to be less have less of ability to regulate their intake in response to hunger and fullness cues. And so if we think about, what might be the problem here, why might we see these differences between infants who are breastfed versus formula fed? There's probably a lot of different things going on here. It's likely complex. So there might be many different intervention points that we can think about. And so we can kind of break this down into thinking about what the baby's being fed, so the composition of the milk they receive, versus differences in how they're fed or the feeding mode. So in terms of milk type, we know that there are some really important compositional differences between breast milk and formula. And formula producers are constantly reformulating a formula to try to better mimic breast milk. So you've maybe, if you pay attention, seen that over the past decade, but even longer than that, we see all these tweaks. And so now we see probiotics and partially digested proteins and many different changes that are kind of constant attempts to make formula more like breast milk. But there are probably certain things that we will never be able to replicate, like bioactive components. So these are hormones that are coming directly from the mom's body and being put into the breast milk that we think are ways of the mom's body helping the baby to regulate how much they eat and their growth needs. We also know that breast milk has a lower protein content and a higher free amino acid content than formula. And research has shown that both of these things are likely influencing babies' intake and their growth rates in a way that is favorable towards breast milk and not formula. So bottom line is what's being fed matters. And so one potential intervention point here is to, if families need to bottle feed, try to support them in expressing breast milk and getting that into the bottle as much as possible, or also being aware that there are important differences between breast milk and formula, that they might need to use behavioral methods to make sure that their baby's not consuming too much. In terms of feeding mode, there are likely important differences between feeding from a breast versus from a bottle. And even these two pictures illustrate these potential differences, right? That when feeding from a breast, there's a more natural positioning of the child to interact and make eye contact with the mom. That can be achieved during bottle feeding, but it's also a lot easier to have feeding positions like you see in this picture where the baby's facing outward and eye contact and social interaction are not as easy, but also for the baby to be, put into a stroller or a feeding chair and left to feed on their own with the bottle propped up. So overall, we know there are probably a lot of important behavioral differences going on here. And so in particular, research has shown that during breastfeeding, it's much more likely that both the caregiver and the baby are contributing to feeding interactions. That if you remember back to what I was saying before about the demand and supply system, the baby needs to be an active partner to make breastfeeding work. So that means that you really need the baby to actively latch onto the breast and to be sucking and to be communicating to the mom's body about how much milk to make, when all of this is not actually as necessary with bottle feeding. It's a lot easier to push a nipple into a baby's mouth and to have the milk kind of flow in without active sucking, or at least the same strength and engagement of sucking as you would see with breastfeeding. We also think that it's a benefit that the mother has less information and control. If she is forced to trust her baby's behaviors and cues and let her baby be an active partner in the feeding, this means that she has less ability to control how frequently and how much the baby consumes, which she could potentially do during bottle feeding. And as I mentioned, there are fewer opportunities for less desirable practices. So during bottle feeding, a parent could encourage bottle emptying. They could prop the bottle up on a towel or a blanket and not be involved in the feeding. They could put milk, or they could put things like juice or add cereal to the formula during bottle feeding. So there are many ways that we might need to support parents during bottle feeding to help them understand what's healthy and developmentally appropriate during bottle feeding, and ways that they can make bottle feeding more like breastfeeding to try to achieve the behavioral benefits that we see with breastfeeding. So again, to kind of sum this up even more, that although, bottle feeding is our alternative to breastfeeding, and it's often what we go to when breastfeeding is not working or we're having problems with breastfeeding, we can think about these, quote, features of bottle feeding, the things that make it an easier feeding method, to actually be things that we want to counteract, that they may actually increase risk for overfeeding for babies. And just as this photo illustrates here, we can never do this with breastfeeding. We couldn't have 2 people feed 7 babies, but we can with bottle feeding, because it affords all this ease that's not necessarily desirable. So during bottle feeding, an infant can be a passive recipient of the bottle. They don't have to work as hard to get the milk out. We also know that during breastfeeding, you get these nice kind of fluctuations between what we would call non-nutritive sucking, where the baby's just lightly sucking on the nipple, but not getting any calories out, and nutritive sucking, where there's actually calories being dispensed to the baby. But during bottle feeding, it's all nutritive sucking. So especially if a family is using food to soothe their baby, that they're trying to get their fussy baby to calm down by feeding them, this might be less of a problem during breastfeeding, because you're not always getting calories when that's happening. But during bottle feeding, it would mean that baby's always getting more calories than they need because their family's using food to soothe. During bottle feeding, a baby can suck at a slower rate, and there's more efficient milk transfer. So they're just working less hard during that feeding experience in a way that makes it easier for them, but also potentially less engaged. And as I mentioned, during bottle feeding, the caregiver has more information and more control over the feeding. So if that caregiver has certain ideas about how much their baby should consume, if they're worried about their baby eating enough or gaining enough weight, they have much more ability to encourage their baby to eat a certain amount or to finish the bottle, and potentially to eat beyond their fullness cues. So, one way that we could approach these differences and the differences we see in feeding outcomes and weight outcomes for babies is to promote and support breastfeeding. And we do want to do that, right? This is really our ideal, is to get to support all families to breastfeed as much and as long as they can for the benefits of their babies and families. But I think it's really important to point out that bottle feeding is often our reality. And despite giving much support to families, sometimes their situation, the mom's need to return to work, or broader issues may just make it very hard for families to meet their breastfeeding goals. And so we see that even if families are breastfeeding, often most of these families are giving their babies bottles. And so that still presents these bottle feeding issues that I highlighted, even if breast milk is being offered. But we know that by 6 months of age, 75% of breastfed infants are also receiving formula, and 16% of infants are exclusively formula fed at birth. So bottle feeding is a ubiquitous part of infant feeding, and we can't just ignore it or just focus on breastfeeding promotion, because these bottle feeding families need support too. So to summarize this section of the talk, we know from decades of research that what and how infants are fed matters. We ideally want to get families breastfeeding and as much breast milk to babies as possible, because we know there are just so many health benefits of breast milk, many of which are very hard to replicate within formula. And these unique properties of breast milk in particular support healthy growth trajectories for babies. We should also recognize that these quote features of bottles that make them an attractive alternative breastfeeding may actually facilitate overfeeding for some families. So we should be aware of these potential vulnerabilities and be prepared to support families to understand them and hopefully overcome them. So although promotion of breastfeeding is ideal and something that we should fiercely protect and support, we also want to recognize that bottle feeding is a ubiquitous part of infant feeding, and we also need to support healthy bottle feeding for the families we serve. All right, so let's think about then how we actually do that. How can we promote responsive bottle feeding? And I really view this as a secondary prevention strategy that hopefully promoting breastfeeding is our primary method of prevention, but we also need to have these additional strategies so that when breastfeeding maybe doesn't happen or families need additional support, we have other ways of supporting them through promoting responsive bottle feeding. And I view this work to be really important because there are studies that are really documenting that these formula and bottle feeding families are very underserved. And so there are several studies that have actually talked to formula feeding and bottle feeding families or looked at the types of support they're receiving in places like WIC or their primary care, their pediatric offices. And these studies show that these families don't feel supported and they aren't getting high quality support. So in particular, one study showed that 1 in 5 formula feeding families received no advice or support in the various contexts they were looking for support from. And other studies have shown that when these families do get advice and education, it's not great. It's inadequate, and this may be due in many contexts in part to a greater emphasis on breastfeeding and breastfeeding support, and maybe a general attitude that if you talk about bottle feeding, that's going to compromise breastfeeding or breastfeeding support. So this means that many caregivers must rely on their own judgment or non-professional sources. They may be going to social media or friends and family that may be giving them lower quality information or advice that's not evidence-based. So in particular, we did a study where we did focus group with WIC mothers in the PHFE or the LA County WIC program. And we asked mothers, both breast and formula feeding mothers, about their experiences in WIC, especially as it related to infant feeding and why formula feeding families, may or may not feel supported within WIC. And what we found from this inquiry about what's the experience of formula feeding mothers as WIC is that there were kind of 3 main themes that came out from these focus groups. The first is that these moms reported feeling judged for not breastfeeding. And one quote that illustrates this theme is a woman who said, "With my son, I felt judged once I had to switch over to formula." And they would be like, "Well, have you tried this?" And I tried everything. I was just like, I can't, I stopped. And because WIC is very big on breastfeeding, that made me feel like I wasn't doing my job. During those times, I felt very judged. These mothers also told us that they perceived WIC as a formula provider. And they didn't realize all the kind of social support and other benefits that WIC provided them. And other research has shown that formula feeding families are much more likely to drop out of the WIC program when their babies turn 1 year old, instead of going through the full 5 years that they could. And part of this may be due to this perception that once their formula benefits end, is WIC really worth it to them? If they don't get that same level of social support and support for their feeding choices, they might not feel it's worth it. And that means that they're missing out on a lot of important support and benefit that WIC could provide. So a quote that supported this theme is, I think the breastfeeding people get more and formula get less, so they just don't want to continue with the whole process. Finally, we heard that there were difficulties attaining the desired amount of formula, that these mothers felt that they had to fight to get the formula that they felt like they needed for their baby due to policies or perceptions of WIC staff. So one quote was that the staff is reluctant to give formula. Although we know the goodness of breast milk, we still choose to formula feed. It's our option. Maybe WIC can support our personal option if we choose to formula feed. So this research and others, it's kind of made us really try to understand, so what can we do about the situation? Because we want to protect and support breastfeeding, but we also want families to feel like they're being served in the way they needed, especially for families in WIC programs and other programs that are serving these families in need. We want to make sure that they're getting the support they need so that they stay in our programs, they stick with us, and that they get what they need to be the best they can within the context they're in. And so one thing that we've been thinking about is, how do these forms of support differ? Not just, how are they perceived by families, but can we look at the types of support we're giving to breastfeeding families versus formula and bottle feeding families? Can we evaluate, how they're different? And much like we think about with breast milk and formula and trying to make formula as like breast milk as possible, can we think about this with support too? If we get all these great benefits from breastfeeding support, can we make our bottle feeding support analogous so that families feel like they're getting support, their choices are being respected, and that they're getting the high quality education they need to bottle feed their babies well? And so when we think about a breastfeeding class, or what a lactation consultant or a peer breastfeeding educator might be doing, they're giving a lot of education around positioning and latching, recognizing your baby's hunger and fullness cues. What are the signs of a good feeding? How do you know that your baby's satisfied and getting enough milk? What are some common breastfeeding problems, and how can we maybe do some anticipatory guidance so that families are able to recognize these problems and either make some changes on their own to fix them, or get help early in advance of these problems progressing. They may receive some education around paced bottle feeding, which is a method of bottle feeding that the aim of it is to ensure that there's not a preference for the bottle, and to make sure that breastfeeding is still being supported. And we have this whole profession, right? Lactation consultants who are dedicated to supporting breastfeeding mothers. So this is a lot of great support, and we have great research showing that this works, that this helps, that these are really great ways to support breastfeeding, especially if we can give this support and education early and often. When we then look at what we typically give formula or bottle feeding families, it's not as robust often, right? And I was able to see some of the materials that you share with your families, and they were a good start. But what I saw in those materials was similar to what we often see in these materials, is that there's a big focus on how much to feed, right? Like ounces per age type guidelines, how often to feed. And then there's information about safe preparation of formula and choosing the right formula. So this is all important, but in my mind, it's no wonder that a bottle feeding parent might be more attuned to how much is in the bottle and getting their infant to feed a certain amount, because that's often the advice we're giving to formula feeding families. And so our question is really, how can we even this out a little bit? And how can we maybe take some of these great lessons that we give to breastfeeding families to support breastfeeding, and also give these ideas to formula and bottle feeding families, so that there's less emphasis on a certain amount and frequency of feeding, and rather, guidance around the importance of, regardless of whether you're breastfeeding or bottle feeding, recognizing hunger and fullness cues, looking at your baby's behaviors as signs of a good feeding, but also maybe some targeted intervention around common signs of overfeeding, or things that we should watch out for. We could teach our bottle feeding families about paced bottle feeding as well, and have them interact with consultants who are well educated on their feeding needs and how to support them through their feeding journey. So in our research, we've been trying to think about, what are some ways that we can support these bottle feeding families? What are some promising strategies for promoting responsive bottle feeding? And so one aspect of this that we've been interested in is this idea of the context of feeding, right? As I've mentioned, the idea that during breastfeeding, there's less information, which may actually be a good thing in terms of attuning families to babies' cues and letting those cues guide feeding. And so we've done a series of studies looking at whether we can make some changes to bottles that might support more responsive bottle feeding interactions. And so in particular, we've done an experimental studies where we've examined what happens when we give a mother a conventional clear bottle on one day, and we observe the feeding interaction. And on another day, we give her an opaque and weighted bottle. So essentially this bottle is the exact same bottle, but it's really covering up those contextual and tactile cues. So the mom has less of a sense of how much her baby has eaten during the feeding because she can't see or feel how much milk is still in the bottle. And we found that when we compare moms feeding using these two different bottles, that there seems to be an improvement in responsive feeding when moms are using the opaque weighted bottle, that they show greater sensitivity to their infant's cues. They feed their babies less express breast milk or formula, and they feed their babies at a slower pace. So there may be some benefits in tweaking the bottle a little bit to remove these bottle-based cues. And we're currently wrapping up a longer term study of this to look at what happens when we give families these opaque bottles over time to see if it helps kind of promote responsive feeding and the development of that over time, as well as moderate weight gain for bottle-fed babies. There's also research looking at bottle size too, that we see sometimes that families may be using bottles that are too large for their babies. And so similar to the idea of, portion sizes for adults, you may have heard of research showing that when we're served larger portions, we eat more. This research suggests that when we use larger bottles with babies, their babies eat more. And this research suggests that when families are using larger bottles, this is associated with greater intakes for their babies, increased intake and weight gain during early infancy, as well as over the first 6 months of infancy. So we may be able to do some counseling around making sure that babies are being fed using a bottle size that's appropriate for their age, so that families can kind of better understand the appropriate, what's developmentally appropriate to expect of intakes. Pace bottle feeding is often taught in the context of bottle feeding, and so it's something that we can, think about teaching our bottle feeding families as well as a way of making bottle feeding more like breastfeeding. I do want to acknowledge that there's not a lot of research on bottle feeding, so technically it's not an evidence-based practice because we don't have great data to support the claims. But I do think it's worth mentioning that conceptually it really aligns with a lot of the things that we think about with responsive feeding, because the kind of practices around bottle feeding are making sure that the infant is being held. They're held in a position that allows them to kind of be actively engaged in the feeding and work at the feeding versus just be a passive recipient of milk. The parent is encouraged to position the bottle horizontally so that the infant has to work to extract milk. And the feeding is started in a way that isn't just, pushing the nipple into the baby's mouth, but actually brushing the infant's lips so that the infant has to actively latch onto the nipple, and the parent is encouraged to wait for that. There's also messages around taking breaks and watching for infants' cues to pace the feeding. So overall, this may be a nice approach to, or a nice package of, behaviors to communicate to parents to help them understand the importance of pacing the feeding in response to their baby's cues. We also recently developed an intervention to support responsive bottle feeding that we tested within the WIC program. And so this was another collaboration with the PHFE and the LA County WIC program, where we looked at whether we could not just do individual level education, but actually work at the level of the WIC clinic to do policy systems and environmental change intervention, meaning that we were trying to change the culture and the practices around supporting infant feeding within the WIC clinic to see if that could help promote responsive bottle feeding and moderate risk for rapid weight gain for WIC infants. And so for this intervention, we had two strategies that we developed. We evaluated what was going on in WIC and tried to see where we might be able to make some changes to better support bottle feeding families. And so the first strategy was that we developed additional resources to kind of balance out the support that was being given around breast and bottle feeding. And so this included educational materials around responsive bottle feeding. We rebanded their breastfeeding warm line to be an infant feeding warm line. So we are encouraging all families to call this warm line if they needed help with infant feeding or had questions. We had text messages that we sent that really maybe targeted specific concerns that bottle feeding families may have, like, are you running out of formula too quickly? That you can think about responsive bottle feeding and encouraging them to call our infant feeding warm line. And we also had handouts and kind of educational points that WIC staff were trained on to specifically support conversations around responsive bottle feeding and helping parents understand what this is and how they could achieve it. We also revamped their assessment and intervention strategies around early infant feeding decisions so that we had a really strong foundation for tailored intervention. And so initially, the forms that they were using at the newborn enrollment were very focused on breastfeeding and supporting breastfeeding and identifying problems with breastfeeding. And that was really important for supporting breastfeeding and supporting breastfeeding families. But it also meant that there were certain families that weren't well assessed and their issues maybe weren't being identified because this strategy wasn't allowing the staff to be kind of guided towards identifying those and educating around them. And so again, you can see the example of the original form here that was really focused on how's breastfeeding going? Are you having any pain? How confident are you feeling? A number of questions to really identify where to refer the family to and what's the kind of breastfeeding support they needed. So we revised these enrollment forms so that they would allow for a much more inclusive assessment of early feeding. And so we revamped it so that there was first a screening question that got a sense of what the family was doing. Were they breastfeeding only with no pumping? Was there breastfeeding with pumping? Were they breast and formula feeding, or were they formula feeding only? And there was probing to see, how are you feeling about this? Do you want to talk about breastfeeding, so that there could be still that early conversation and support for breastfeeding. But once they established kind of where a family was with their feeding decision, then we had these targeted assessment forms that were very specific to what the family was doing. And so this was the form for a family that was breastfeeding and there was no pumping. So this, again, was very focused on what issues are you encountering and how can we help? But then there was a separate form for families that were breastfeeding and pumping that had specific questions around pumping and bottle feeding. There was another tailored form around breastfeeding and formula feeding. And finally, a tailored form for those families who were just formula feeding, so that they didn't have to go through, any of these breastfeeding questions if they were already pretty solid with their decision and indicated that they didn't need support around breastfeeding. And so to dig it in a little deeper into these forms, each form was designed to guide counseling and education. So you can see in the first column, you can see that this form was the formula only form. And so in the first column are the questions that the WIC staff would ask around, how does your baby let you know he or she is hungry? Do you feed your baby on a schedule? So this section of questions is really getting at this understanding infant cues and responding to them. Get a sense of what the family knows about responsive feeding. Then the staff was guided around, what the family responded, what to do about that. So in the case of these questions, if the mother seemed to have a pretty good sense of, what the baby's hunger and fullness cues were, and seemed to be responding to those cues in a way that was responsive, then no further counseling was needed. But if the family was responding in a way that indicated that maybe they needed more support around learning infant cues and distinguishing hunger and fullness cues from other needs, then they were targeted as a family that needed more counseling. And then there was a specific connection in this last column to the resources that they should use. And these are all, the WIC standard education that they were already using, but really just kind of tailoring it and contextualizing it to the family's responses and needs. So again, this provided an opportunity for a much more robust and inclusive assessment of early feeding decisions, not just breastfeeding, that was then really clearly connected to opportunities for tailored intervention. And so this means for breastfeeding and bottle feeding families, many of the same things were being assessed around what are your feeding patterns, how do you recognize over and under feeding, what's good positioning, how do you recognize these cues and recognize that there's been a good feeding? What are some feeding problems we can anticipate? And how can we better inform you around things like responsive feeding and paced bottle feeding? So overall, this provided staff, empowered staff really to have the questions and the resources they needed to support responsive feeding, but also allowed them to provide unbiased support that met the mother's specific needs, regardless of whether she was breast or bottle feeding. So those were the strategies that we developed, and then we tested them within an 11-month study where in March of 2019, we selected 3 intervention and 3 matched control sites. We spent a month training staff at the intervention sites and then collected data. We intended to have outcome data through 11 months, but unfortunately COVID interrupted that. So we were really only able to get outcome measures through 6 months. And then the 11-month assessment occurred during COVID. So it was a little weird. So we have data through 6 months that we can present in terms of how well this intervention worked. And one important thing that we wanted to look at was whether there were differences in breastfeeding at the intervention and control clinics. And so the PSC clinics here that you see are the intervention clinics, and then the control clinics are the clinics that just had business as usual care. And when we looked at the rates of exclusive breastfeeding, any breastfeeding, or exclusive formula feeding at the 2 different groups of clinics, we saw no differences. So we can say that our implementation of these supports for responsive bottle feeding did not impair or hinder breastfeeding at these intervention sites. And so you see the assessment age across the x-axis and the prevalence of the different types of feeding along the y-axis. And you can see both the intervention and control clinics at 6 months, about 35% of families were doing any breastfeeding. We did see, though, that in these intervention clinics, these efforts to promote responsive feeding were associated with reduced risk for rapid weight gain for infants. And so this figure here shows the intervention clinics with the green bar and the control clinics with the yellow bar. And we have the prevalence of the percent of infants exhibiting rapid weight gain across the first 6 months. And it was significantly lower in the intervention clinics compared to the control clinics. And we can see the odds ratio here indicating that that was a significant difference in the prevalence. So that was what we were hoping to see, that we could have meaningful impacts on infant risk for rapid weight gain by better supporting bottle feeding families and targeting risk factors for overfeeding and rapid weight gain. And we were interested in digging a little deeper too, to really try to understand like the behavioral mechanisms here. So what was it that families were doing differently that might have impacted their baby's weight gain? And when we dug a little deeper, we actually found that the intervention was especially helpful for mothers who reported that they had fussier infants. And this was measured by a temperament questionnaire. So these moms who, filled out the temperament questionnaire, and from that gleaned that certain infants had a more negative temperament. So they were fussier and more sensitive, maybe had a lower threshold for stimuli. These babies seem to particularly benefit from the intervention. And this is aligned with research showing that these infants with more negative temperaments, more negative affectivity, they're at risk for overfeeding. We see that often families who are faced with more negative or fussier infants, food is a big part of how they're soothing their infants, getting their infants to calm down. But this can mean that they're being fed, beyond their hunger and fullness, and perhaps these families need non-food related strategies to soothe their infants and to kind of manage their infants' greater fussiness. And we see that this greater feeding frequency, use of food to soothe, is associated with greater risk for rapid weight gain. So these are kind of our higher risk infants in many ways, but especially in terms of overfeeding and risk for rapid weight gain. And so we saw that these mothers who reported having fussier infants, those mothers who were in the intervention clinics reported less frequent use of food to soothe. They were feeding their babies less frequently, and they had babies who exhibited slower rates of rapid weight gain. So overall, it seemed that the intervention was really maybe targeting these families who needed support the most, because they had more behaviorally challenging infants. So overall, what we've talked about is that these bottle feeding families report feeling underserved, and we know that the quality of the education and resources available to them is lower. So there's a real need here to develop more supports for responsive and healthy bottle feeding. And ideally, those supports will complement the breastfeeding supports that we have, so that we have really robust support for both, depending on where a family is and what type of support they need. Our research has shown that responsive bottle feeding is possible and can be promoted by targeted strategies. And so in particular, overall, to kind of wrap up our talk, and then I'll welcome any questions that you have. What we've talked about today is that infancy is a really important period for obesity prevention efforts. And in particular, we see responsive feeding as a really important target for our intervention efforts because of the benefits it has both for physical health and growth, but also, I didn't go into it as much today, but benefits for social, emotional, and cognitive growth fostering as well. Breastfeeding and responsive feeding are complementary. So we know that if we can support responsive feeding, we're probably going to support breastfeeding, and vice versa, that in supporting breastfeeding, this is likely helping caregivers to develop a more responsive feeding style. But we can also support responsive bottle feeding. And we have many strategies that we're developing and testing and that show a lot of promise. So in particular, these promising strategies that we discussed today are making sure that we're providing robust education to families that's not just focused on how much and how often to feed, but really making sure that they're considering the baby to be an important part of the feeding or interaction, that they're learning about feeding cues, how to recognize hunger and fullness cues and distinguish them from other needs like tiredness or just the need for a cuddle or reduced stimulation. And that we can communicate to parents that feeding cues are important regardless of whether they're breastfeeding or bottle feeding. We can continue to think about ways that we can make bottle feeding more like breastfeeding, both in terms of the milks babies are receiving, but also behaviorally in thinking about how we can make sure to preserve these important benefits of breastfeeding that maybe make it a little more work, but also make it more beneficial for caregiver and baby. And then we talked about some ways of providing targeted support to reduce risk for rapid weight gain, whether it's thinking about the ways bottles are being used, the contextual cues that bottles are afforded or are affording to families, as well as thinking about how we can make sure that we are thoroughly assessing early feeding and thinking about ways that we can provide the support that formula and bottle feeding families need to reduce the risk for rapid weight gain. So all of the materials that I discussed today from our WIC intervention are available to you. So if you're interested in reading the papers from the study that I discussed, or looking at the assessment forms that we created, or the educational materials that we created, you can visit our lab website, healthykids.calpoly.edu, and there's a responsive bottle feeding tab there that has all these resources, and I'm always willing to help too. If you reach out, we can provide you additional support, and the QR code here too will lead you to that website. I also recently released a book on promoting responsive feeding during breastfeeding, bottle feeding, and the introduction of solid foods that talks about some of the research that I talked about today and more. So if you're interested, you can visit my website and check out that book. I also want to acknowledge that we've had a lot of great support for this research. Much of it has come from the National Institute of Child Health and Human Development, as well as Robert Wood Johnson. We've received support from the Sims-Mann Institute for Early Childhood Development, the Bill and Linda Frost Fund, and Drexel University College of Nursing and Health Professions. So without that support, this work would not have been possible. I really appreciate your time and being able to share all this work with you, and I'd welcome any questions that you have about what I presented today or anything else you're curious about. So thank you.
Did anyone have any questions? Okay, well, if you think of any, Allison's info will be here for you. I am going to put the evaluation into the chat one more time. And we're giving you a virtual round of applause, Alison. Thank you so much for being here with us. Thank you for sharing all of the information. Again, the evaluation is in the chat. If anyone has any questions for myself or Terry, we are here in the background. We'll be here. Other than that, have a great rest of your Monday. Have a great rest of your week, and check in with us if you need anything else.
Thank you, everyone.